Up next is someone with us for the very first time, Dr. Amos Dodi, a clinical fellow at the University of Michigan and works with the pulmonary team. We welcome him to tonight's event and hint, hint, hope this isn't the last time that we see him. Welcome, Dr. Amos.
Just give me 1 second. I'm trying to set up the computer. Okay. I'm Dr. Dodi. I'm from the University of Michigan Pulmonary Department. So today I'm going to talk to you a little bit about what's going on in the therapeutic arena, a little bit about adult life, transition to adult life with CF, and maybe try to give you a little bit of hope. All right. So most of the data in my presentation is taken from the CF Foundation's 2013 Patient Registry Annual Data Report. It's available on the CF Foundation website. It's a wonderfully constructed document. It's a pretty light read, and I recommend everybody should read it. The information from the registry provides very important data to help us identify new health trends, new treatments, and Shelley already spoke about what exciting things that happened earlier this year. I'll talk a little bit more in a more generalized terms about what happened recently. This also helps us designing new clinical trials and practice guidelines. And there are about 28,000, I believe, in 2013, 28,000 people with CF who have been on the Foundation's registry. So it's a lot of people and it's a lot of data. So when I started med school in 2001, so that's right around here, the median survival for people with CF was about 30 years. So 50% of people made it, 50% didn't. By now, by 2013, when I say now, I mean the 2013 data, it's increased by more than 33%. It's now close to 41 years, and I can't think of too many diseases that we see something like that. So it's really, really remarkable what's been happening in CF. So this is the age distribution for the CF population in 2013. As we all know, the majority of the people will be, more than 50% are 18 years or younger. What we see is that in 2013, there are 2,700 people with CF over the age of 40, which is almost 10% of the population. And I think that's a remarkable achievement. It's a lot of progress. Now, another way to look at this is this. In 1986, okay, there were about 5,000 CF patients that were older than 18. Now, 30 years later, the number more than doubled. And now about half of old people are over the age of 18. So I don't think I need to convince you that things are getting better. Things are getting better fast. Okay? Now, some of you might have heard of FEV1. I'm not going to go into terms. It's a measure that we use to. It's a surrogate measurement of how we estimate lung function. It's how much air and volume you can blow out in 1 second. And it's very predictive, and it's not used only in CF, but it's very useful in CF. So as you can see here, this is the median FEV1 % predicted by age and the birth cohort. So if you were born in 1984, you started right here, and by age 29, you're here. So we use 70% as the borderline between normal, mild, and not. And so you pass the 70% at age 20. If you were born in 2004, 2008, we don't really see much of a decline. And so, if we assume that things are going to go, the trend is going to continue, I think that, we're going to get there probably age 30, which is 10 years, 10 more years of normal lung function, which is really really great. Now, so this looks at severity of lung disease by age. Okay, it's a series of snapshots of FEV1, and this is all in 18-year-olds. Okay, so as you can see, we were 24% here, and in 2013, we see a decline of 70% in the people with severe disease. So 70% less severe disease that we see. So I don't want to discriminate against people who are not 18. So the 10-year-olds, they improved from 1993 to 2013, 10 points, which is 15%. For the people who are older than 18, they improved from 62 to 83, which is double that. It's 30%. So the improvement that we see it a lot in older people. Okay, and that's a lot of hope. So a little bit about CF. I'm not going to go into too many details. As you know, you need 2 defects of the gene. You need a defect in both copies of the gene. Some patients have less than that. And then that gene is actually the recipe for an ion transport channel, okay? Which, if that's defective, you have airway surface liquid depletion, meaning things dry up. And then the mucociliary are the things that make the gunk move up. They don't really work because the gunk is really, really thick. So the mucus collects, as you all know, and hot mucus sounds great for bacteria. It's yucky. And that leads to inflammation. And inflammation leads to more mucus obstruction. And there's a vicious cycle that goes on right there. So in approaching the disease, how are we going to treat it? And so traditionally, standard treatments were just, the mechanic of cleaning a clogged pipe. So we try to clear it, mucolytics, hydrators. Then we started treating the infections with inhaled antibiotics and now powdered. And we gave pancreatic enzymes and vitamins because the same stuff that happens in the lung happens in the pancreas. And azithromycin, which decreases the inflammation. It's an antibiotic, but it decreases the inflammation, and it's used the same in COPD. And finally, there's been lung transplant, which frankly hasn't been that great. It's not a fix. So the more novel approaches now is, dare I say it, gene therapy. Now we're allowed to say it. And the modulators. So I'm not going to scare you. I'm not going to talk about all the mutations. There are 1,900 mutations. The most common one, as you've all heard of, is the Delta 508. Okay, about 50%, 47% are homozygous, meaning both have the defect, and 40% have only one defect. There are other mutations. Some of them are targets for the drugs that we see now. Okay, so, but I don't want to talk about it too much. I'm just going to say that the different mutations code for different problems. And I'll give a couple of examples. So the CFTR modulations. So this addresses the underlying genetic defect. Okay, this is mutation specific. As you heard before, this is personalized medicine. This is moving very fast, and CF is by far the most advanced field in personalized medicine. And this is going to help other fields, and other fields are going to help CF. And this is going to be a very good synergistic interaction with other fields of medicine and other diseases. Our relationship, as I mentioned before, with the CF Foundation is really important, and the CF Foundation developed partnership with biopharmaceutical industry in 1998 to discover new treatments. This is speeding everything. This is allowing industry to get access quickly to populations of patients that they're interested in, and it very, very fast rate of production, and it allows us to go forward with you have these small molecules that can actually affect this ion channel that doesn't work. So, you've heard of ivacaftor and lumacaftor. I don't know if you've heard of that, but those are the two main players right now. And so ivacaftor just increases the activity, so the CFTR is there, but it just makes it work faster and harder. And the lumacaftor, increases the quantity of the CFTR. So this is, I didn't want to put this slide, but it's a must slide for a presentation on cystic fibrosis, and that's the pipeline. And so what you see here, and the way to look at this is actually to start from the bottom. So right here is what's available for patients. Phase 3 is the definitive trial. You start from the preclinical, and you go through the 3 phases. And as you can see, they're different categories of the medications that I mentioned earlier. If you notice, the CFTR modulation, they're all in very, very early stages. And only Kalydeco is currently available, although that's changing very rapidly. So again, there's a lot of stuff in the pipeline. There's a lot of hope. So what about adults? So in 2013, of adults with CF, 46% were working, some full-time, some part-time. 22% were students. 30% had college degrees, and 33% had some college education. So as people age in CF, as in normal life, people are starting to do what people without CF do. They get college degrees, they start families, they get jobs, they move on in life. And that's really great because that's what we want to do. So this is you've all heard the names of the respiratory organisms, Staph aureus and the Pseudomonas and all those scary names that we don't really know what they mean. And by far, this is not a static thing. CF is not a static disease. It moves. When you treat it, sometimes it feels like a moving target. It's very difficult sometimes. So as you can see, Staph aureus, later on in life, this is according to the years. I'm going to get to how it changes with age. But through the years, we see that Staph aureus becomes more common, and Pseudomonas is coming down. So there are different ways to account for that. We can detect Staph aureus better, and we've really fought Pseudomonas hard. So there are a lot of confounding variables that go into this, but it's important to know. Now, there's also a change in the organisms that you fight with age. And so with age, as you age, as you can see, the Pseudomonas becomes more prevalent, and the Staph aureus goes down. And again, this is important because the organism that the person had at age 15 is not the same organism the person's going to have at age 45. And I say 45 because there are patients who are 45. There are patients who are 60s and 70s, and people get diagnosed later on in life now. Okay? So there are also other things that happen because of cystic fibrosis. And you've heard of some of these, but I think, some of the more important ones are diabetes. And as you can see right here, over 40% of people with CF will have diabetes by age 40. And about 20% of CF patients use insulin. That's a lot of people using insulin. So it's very important to notice these things. Sorry, I went back. Other problems, so they're bone disease, joint disease, they're the liver disease, the pancreatic problem, all of these problems. And of course there's depression. I'm going to talk a little bit about depression, okay? But with regards to diabetes, so we see that cystic fibrosis-related diabetes is increasing, okay? And it's increasing in patients 18 and older. It's also increasing a little bit in the under 18. I don't really have a very good explanation for that, okay? So the CF Care guidelines recommend that people at age 10 or older should undergo oral glucose tolerance testing yearly. So if you or your family member haven't been tested in a year, you may want to discuss this with your doctor. And as you become older, it's more likely, so it becomes more important. And I think we're all moving towards a multidisciplinary approach where there's nutrition that becomes very important and social work and all of these things. So it's very, very important. And, you know, it's very difficult to take care of patients. It's not that easy because there are a lot of things that go into it. And I think it's always good, it always feels good for the doctor when the patient takes charge and the patient is on top of their stuff. And they know what they need to do, and they know what and if the doctor forgets something, because doctors do forget. Ask lawyers. Doctors forget. And it's really helpful if you can partner with your doctor and, you know, be on top of it and have your folder and be ready, okay? So I'm going to talk a little bit about depression, really, really briefly, okay? Like a minute, okay? So this is very troubling. So if you notice, and the arrow kind of clues you into what I'm going to talk about, in this age group, 11 to 17, we see depression right here. Between 18 and 24, it triples. And that's very, very worrisome because depression affects everything. Depression affects compliance. Depression affects health, and we don't even understand how they interplay together very well. But we know they do. We know that depressed people don't do well, okay? There's the TIDES trial is currently ongoing, and it's studying the rates of depression and anxiety in people with CF. So you can go on the CF Foundation website and if you want to join that. And I think it's important that parents communicate with the healthcare team if they see signs of depression. So what are signs of depression? So feeling helplessness and hopelessness, loss of interest in hobbies, daily activities, weight changes, sleep changes, anger, irritability, loss of energy, self-loathing, reckless behavior, difficulty concentrating. Wait, but we're talking about teenagers. And that sounds like a lot of normal stuff you see in teenagers. I was a teenager not too long ago, and I think I felt like most of those within a week, I felt like most of these. So this makes it very, very challenging, and I think that getting to know the physician, getting to know the healthcare team is really important because we learn to trust each other, okay? And sometimes, you know, a parent or a family member or a friend, without knowing, can tell the physician or the healthcare team that something's wrong. They don't know that something's wrong. They're just describing what they see, and that's very, very helpful, okay? Because that, for me, as a pulmonologist, that could really be important because that really affects compliance. So I really need to know what you're doing and what you're not doing, okay? So if you need a little energy shot, I need to know about that. All right. And we see also a lot of rates, higher rates of anxiety, and that's increasing with time. So finally, no CF talk is complete without talking about lung transplant. So for people with severe disease, lung transplant is an option. It's important to remember that lung transplant has its own risk. We often describe it as exchanging one disease for another. It requires lifelong post-transplantation care. In the initial stages, I think post-transplant care is more demanding than cystic fibrosis. And of course, there's a wide spectrum, but even serious cases. Of people with CF, over 80% are alive in 1 year after the transplant, but only 50% are alive in 5 years, and that's really a bad number that we would love to change, but I think we've seen it going like that for a while, so it's not gonna change that quickly. Okay, just so you know, in 2013, all of 250 people with CF received a transplant with a median age of 31. That's about it.